Thank you very much. It's really a pleasure to be here. A bit daunting to be the last speaker after so many absolutely outstanding presentations. And you've heard a lot of speakers who are taking you into the future about where we can go with endometriosis. And in a sense, I'm going to take everyone back a little bit first, and then we'll hopefully look forward to moving into the future and see why this talk, which on its face could appear to be a little bit mundane, in fact, is critically important to all the aspects of understanding endometriosis and finding better approaches to it. So let's talk a little bit about why we want to classify endometriosis better. And I know you've heard some comments this morning from Stacy Mismer to understand why this is such a problem. But in many cases, you see a lot of studies and literature, and people are not talking common language. They're, what's severe disease, what's extensive disease, what's minimal mild disease. And in fact, often when you see minimal mild, moderate disease, the specificity of the diagnosis of whether they're talking about endometriosis lesions or whether they're talking about fibrotic tissue or deep infiltrative tissue is really not entirely clear. And in the absence of this clarity on what people are talking about, it's very difficult to standardize comparisons. Are we talking about apples and apples, or are we talking about apples and oranges? And this is especially important, of course, in all the research applications that we're looking at, because if we're not talking about the same thing, we can't really evaluate outcomes, and we can't make plans for how to move forward in the future. Now, in actual fact, trying to decide what we're going to talk about is much more difficult than it might initially seem. There are a number of items on this list here that you can see that are very important for determining a classification system. And indeed, as you'll see in a minute, there has not been a lot of agreement historically over this. And getting a consensus about what should be done is, in particular, among surgeons, who are often fairly individual types of people, has not been easy. And there has not been a lot of evidence that's been applied to it. One of the biggest problems, though, that we have in endometriosis is that it presents with so many different symptoms and so many different signs that people have not been able to agree on what's the most important. Is it pelvic pain that occurs with menses, or is it general pelvic pain? Is it infertility? Is it ovarian masses? Is it rectovaginal disease? Is it pain that occurs with other conditions? How is it related to chronic pelvic pain? And so in the absence of definitions, there's been a great deal of confusion when people try to talk about the literature about what works and what doesn't work. And so we get down to this last item here, recognizes confounding variables. And as you know, and what you've heard today, the confounding variables are all those things that make interpretation of cause and effect very difficult. Now, I very briefly want to run through the history of the endometriosis classification systems, because it really demonstrates the complexity of this issue and maybe helps to guide us a bit to the future. And of course, you've all heard of Sampson, who categorized hemorrhagic cysts first of all. But in the next few years, Wicks and Larson used histology. There were other data that were presented regarding anatomic presentation and malignancy. But right here, we can see all the different things that were used, criteria that were used to stage disease. And then we got into further histopathology and pain, and then different kinds of relationships, and then structure involvement. So nobody agreed on the types of elements that should be included in a classification system. Physical examination, surgery findings. This system by Acosta in '73 was quite popular. It looked at the site and distribution of lesions. And then we had surgical staging based on malignancy type of staging system. Demowski and Cohen in '75 had more systems than Kistner had a very popular system in '77, but it was quite complex, and someone had to spend a lot of time after surgery describing all the different types of lesions. V.C. Buttram from Houston revised and expanded on this, and Cohen added laparoscopic findings. The American Society for Reproductive Medicine was really the first group to come out with a reasonably accepted, widely agreed upon system, which we can see here. And this was done way back in 1979, so we can see this over 30 years ago now, and this is the first system that came out. But there were some real issues with this system. It was felt to be flexible. Fortunately, there was a form so that people would actually write down what they'd found. And it did put numbers on things, although these numbers were all arbitrary. And again, there were arbitrary cutoff points. Arbitrary meaning that experts sat in a room and decided what they thought was important or not, and what was the difference between minimal, mild, moderate, and severe disease. Now, there were many papers right after the AFS system came out that were published to evaluate the classification staging system and say, well, did it really work or not? And in 1985, based on a lot of these papers, the AFS revised the system slightly and published it again. And really, that's the system that stayed in place since that time. And this is what it looks like, and this is what many people have used. But of course, this system did not particularly apply to pain or did not particularly apply to infertility, although it was thought that it would, and it could and it should, but in fact, in many cases, it didn't. And so there were some major limitations with this. It was very arbitrary. The scoring system was arbitrary. How many points do you get for an ovary? How many do you get for peritoneum? How much do you get for deeply infiltrative disease? And of course, the problem was there really wasn't anything for that. There was 40 points for cul-de-sac obliteration, but there really was no attention paid to bowel disease, ureteral disease, or rectovaginal disease. And indeed, when different people looked in a pelvis and tried to score or stage disease, they got very different types of results. The type of lesion, whether it was red or white or black, what have you, was not taken into account in this scoring system, although it's still not clear what gain we'd get from that with the current systems. We'll discuss that some more. And most importantly, there was very poor correlation between extent of disease and pelvic pain. There really has not been a system that showed a correlation. And so how can you use a system if it doesn't, in fact, benefit the patient? There were some studies done that showed that the staging system did correlate with the tubal condition, and some papers were done MRI and laparoscopy and endometriomas, but indeed, at the end, there were very few papers that showed a lot of utility of this system, and there were many papers that showed an absence of correlation with endometriosis staging system. So even though people have been trying to stage endometriosis since 1921, we get to the late mid-80s and 1990s, and there's still 65, 70 years later, no systems that really work. And so the question is, to the current staging system, does it help? And the answer is, unfortunately, a resounding no. So I want to share with you three newer staging systems which are coming along, the last one being one that I've developed for fertility. But I want to mention just briefly a couple of other ones that are out there now that I think have some interest, and we'll see what happens. The first is the Enzian classification system, which comes from Germany, and this was an interesting system that was put together by a number of experts in Germany. And I don't have time today to go through a lot of detail of these at all, but they wanted to look at a number of different aspects of endometriosis and how it might be staged. The people who got together to do this were surgeons, by and large, and so this was really a surgical staging system. And they had a very complex set of numbers, and don't even try to remember them. I can give you the reference for this if you want, because it's a very, very complex staging system. They did have numbers that they wanted to use to correlate this with pain. But at the end of the day, this system is detailed enough that there's almost nobody right now outside of Germany who's attempting to use it because it's just too complicated. And it wasn't, in fact, that clear how it should initially be used. Now, the AAGL has made a real effort over the past several years to develop a classification of endometriosis. And again, we could spend an hour talking about this, and we don't have an hour. So I just want to hit a couple of highlights about this. And I think this is a very important initiative. Chuck Miller's here today. He's been involved with this, and Mauricio Breu from Brazil has been very involved with this, and I've been a bit involved with, along with a number of other people in the room here today, to look at developing a system. And one of the reasons for doing this was the need to identify deep infiltrative endometriosis within the classification. If there's been a singular criticism of the AFS system, other than the fact it didn't really predict much, it was that it did not define deeply infiltrative disease, especially of the bowel, ureter, rectal, vaginal area. And really the only aspect of that was managed was with the cul-de-sac obliteration of 40, which could occur with all different types of disease, but really was not very descriptive. And I think this is a completely legitimate criticism of the system. And so people have started arguing about this, and part of it, I think, came about because of the improved technology, much of which you've seen today, that we had at surgery. And so as surgeons got better at seeing what was in the pelvis, first through laparoscopy, where we just look down the laparoscope, and then with better imaging, and now with much improved cameras and visualization of the pelvis, as we can see so much more in the pelvis, people came to recognize that endometriosis really had a lot of presentations that had not been all that appreciated before. A few surgeons had appreciated, but not really very many. And so as people started to recognize all this extra disease, they said, well, how are we going to describe this? What are we going to call this? Is it just bowel disease, ureteral? How big is it? What do we do with that? So more interest came about, and as you can see, more articles came about. And I want to thank Chuck. The next 2 or 3, 4 slides on AAGL came from Chuck Miller, who's already talked with you today. So the AAGL looked at a large number of patients. You can see this Mauricio's paper here. And you can see the types of patients that were included, and importantly, a lot of the patients had pain. You can see with deep endometriosis, over half the patients had pain, and then others had both pain and infertility, and a small number just infertility. So you can see the distribution of patients. And this is something that's very, very important, because when you develop any type of system, you have to know what kind of patients you're talking about, because they're going to have different presenting problems, different types of disease. You need to know that. And so when this system was started, it was actually just a tabulation system. It went through a couple of iterations. And so tabulation meaning just documentation, as opposed to trying to make a classification system, because to really make a classification system, you have to tabulate the data first, and then you have to analyze it. And so the idea here was to accurately describe morphology or shape of the disease and get some quantification. So it's, you know, what's it look like and how much is it, basically. And this system actually then computed totals. David Redwine was very involved with this. It allowed calculation of fertility index, which was a publication I'll talk with you about in a minute, and included a patient information section, had statistical calculations. And the outcome, the desired outcome from collecting all these data, were to say, if we collect all these data on a lot of people, will we be able to analyze it and determine a better classification system? One of the really important things to look at, of course, is to rate the severity of symptoms, and in particular pain. Pain is very, very difficult to assess. And I personally like this scale, analog scale of 0 to 10, where somebody draws a line about how much pain they're having. But there are some, believe it or not, very significant and legitimate criticisms of this as a measure of pain. And the NIH, for example, does not use this as a measure of pain when they're looking at studies, and won't accept it as a measure of pain. So here we are in 2012, and we still have very significant differences among smart people who are trying to deal with this problem about how do we measure pain, how do we describe pain. And so clearly, if it's difficult to describe it and to measure it, we're going to have a difficult time deciding what it means and what types of interventions can help to improve it. And so in this tabulation system that was started by AGL, there was a lot of information through this, but the concept was abandoned because it was very, very labor intensive. And I can tell you that it is, because personally I keep track of what I've done at surgery, after surgery. You probably know you have to go and write orders on the patient, write notes about what happened, and then you have to dictate an operative note, and I've always kept special forms on my patients. And it actually takes me about 20 minutes after an operation by the time I get finished with all the different kinds of descriptions and things that are necessary. So it takes real time, and a lot of people aren't going to spend the time to do this. So if you want to get a broad amount of data, you have to make it simpler. And so AAGL moved on to a different approach to this, and 30 internationally recognized experts in endometriosis surgery were asked to score endometriosis based on location, amount, and surgical difficulty. And probably everybody who's talked here today has participated in this, and we all filled out this form. Again, I'm giving you a very abbreviated version of this today because we don't have time to go through it all, but we basically put down numbers about how much of a number do we think a different lesion ought to get based on its impact, and how much was this going to affect pain and affect fertility. And you can see all these different numbers for the different surgeons that were down here, and then each of us went across. I don't know where I'm down in here somewhere, I remember that. And I don't think I had too many big outliers. It's always interesting to look and see who thought something was worth a whole lot more, a whole lot less in points. But in actual fact, there was really a lot of agreement on this. And after this was done, and the patients were sort of organized into minimal, mild, moderate, or severe, that they sort of did a little comparison with the stage, ASRM stage, and the count of AGL. And you know, what you see is that there actually is some correlation here, but there's also some real differences. If you look at stage 3, here it comes, you know, a pretty almost even distribution, not quite, but pretty even. You know, stage 4 tends to be more severe, and that's what you'd expect, but there's a lot of overlap. And this just reflects the fact that the ASRM system has some serious difficulties with it, and the AAGL system is trying to be more predictive of outcome. But when you go and you look at the total pain, and I'm dealing mostly with pain on this, for the average AAGL staging, you can see that as the stage goes up, the number goes up, but it doesn't really change much for 2, 3, or 4. So there's some discrimination here between really minimal disease, but not so much among the more severe disease. And if you look at the ASRM, there's hardly any difference at all, which has been the criticism of it, that the scores didn't really predict anything. So the AAGL system seems to have some discrimination in this range. Whether additional analysis will allow a different way of looking at the numbers or breaking them down to give us a more predictive ability will be interesting to see. So the concept is that once this scoring system is validated, recognizing this scoring system came from 30 experts, probably 10 of them in the room today, said this is what we think the point score ought to be for an ovarian lesion or a peritoneal lesion or a bowel lesion, et cetera. We'll try to analyze that and create a statistically based classification system to see if we can find differences. The idea is to have a staging system that will tell us something about how to manage pain. Now, I just want to finish by very briefly going through the Endometriosis Fertility Index, which is an index used to predict outcome for fertility, and this is sort of a lifetime of labor for me. I started coding patients for this about 1982 or 3, and did it for quite a while up through about 2000. I still code them, but for the people that went in this study. And we had 801 patients in this study. There were actually about 1,400, but we had really extensive data on about 801 patients, all of whom wanted to get pregnant. So I want to emphasize that this EFI is only for fertility. It does not apply to pain. And so the concept was that while the ASRM system was a staging system that was good for standardizing reporting, we've already mentioned it had very limited success predicting pregnancy. So the objective that I had in this study was to develop a useful clinical tool. A tool is something that can do something, called the Endometriosis Fertility Index, that predicts pregnancy rates in patients with surgically documented disease who attempt non-IVF conception. I will just mention there's been an abstract that shows it actually does predict some outcomes in IVF. There's reasons for that I could discuss. One of the interesting concepts in this was that we talked about a least function score, which is how good did things look after surgery, and this was considered, this ovary here had just a very little amount of disease, so we give that a score of 4. And just this was an ovary with an endometrioma that you can see. That endometrioma was removed. She actually had bilateral endometriomas on both sides, but the ovaries looked pretty good after removed, so those ovaries got a score of 2 out of 4, which is moderate disease. This is a tube with a bit of endometriosis on it. That tube would get a 2 out of 4. And here's some fimbria at the end of the tube, and you can see there's really scarring in here. And this amount of scarring would make this tube about a 2 as well. So I just wanted to share the principles with it. This is an endometrioma that's been taken out of an ovary that was sutured, and this ovary would also get a 2 because it was smaller. And this is really severe endometriosis here. You can see we actually did shaving of the bowel here, and there's salpingitis eschimocgonodosa in the tubes, and this patient mostly got 1, so really severe disease. So out of these scores of what things looked like after surgery, we made what's called the least function score. It's not important to get into the details, except it basically said what's the worst looking structure on the left side and the right side, and we added up scores, which went down here. And then we looked at other factors that predicted pregnancy rates, but I did not choose these arbitrarily. We looked at about 400 to 500 variables, and we let the data tell us what mattered and what didn't and how much it mattered. And not surprisingly, what mattered for fertility was the patient's age. Younger patients got more points because they had a better chance of pregnancy. Years of infertility really mattered. Less than 3 years is good and more than 3 years is not good. And a patient with prior pregnancy had a better chance of pregnancy, not surprising. So of the 10 points in the endometriosis fertility index, 5 come from history that you know before you go to the operating room. A total of possible 3 points came from the least function score, which is how well did the pelvis look after surgery. And then we had only 1 point out of the 10 came from the AFS endometriosis score, and 1 out of the 10 from the total score, which means lesions and adhesions. So only 20% of the whole score came from the AFS score. These are the only aspects of it which mattered. You add the score up, and we then followed patients, and we actually validated this prospectively on an additional 200 plus patients, and we got the score to see how patients did. And the bottom line was patients with 0 to 3 had only a 10% chance of pregnancy over even a whole year, and as the score went up, the pregnancy rates got higher. And so what we do is we use this after surgery, after we've done laparoscopy, say how good does the pelvis look, what's this patient's chances. Patients down here go straight to IVF, and patients up here can be left for some time with different non-IVF treatment to try to get pregnant. So the point of this, the endometriosis fertility index, is that it is simple, it's robust, it's validated, it's been shown to work, and it predicts pregnancy rates, and it's useful in talking to patients about treatment plans. So I think this is a system that can work for fertility. I know others in the room, Thomas Stouge, who's here, and his group are using it and to see how well it works in their hands. There's a group in Brazil, I think Mauricio Abreu is using it to see how it works in his situation. I'm hoping a lot of people will use it. Maybe it can be improved so that we can have a system to predict outcome to help manage patients. What we need now, as you can see, is a similar system for pelvic pain, and I'm hopeful that maybe the AAGL system, once it's completely analyzed, will give us some increased measure of ability to predict outcome after patients have had surgery so that we can manage their care better. Thank you very much.